Moving on to the next topic, would like to invite the chairperson, Dr. Noni G. Singha, MD, FICP, FICC MD, Senior Consultant, Physician and Diabetologist, Digboy, Assam. We welcome you on stage, Doctor. I think we can have a round of applause.
Thank you, organizers, for giving me this opportunity. It's my privilege to welcome Dr. M. Shunmugavelu, sir, to the dais.
Shall I talk? Because I have been already introduced. Yes. Respected chairperson, senior doctors, my doctor friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on diabetic cystopathy, diabetologist perspectives, with a particular focus on evidence-based findings. I thank my friend, Professor Dr. LSM, as well as the chairperson, for their kind introduction. And what I'm going to do for another 20 minutes, the contents of my talk plan includes introduction, urinary bladder anatomy, physiology of maturation, diabetic cystopathy with reference to pathophysiology, pathogenesis, management strategies, and conclusions. So diabetic cystopathy, a common neurological complication, traditionally described as a triad of reduced bladder sensation, increased bladder capacity, poor bladder emptying. It was first described by Moller in 1976. The modern definition encompasses broad spectrum of lower urinary tract symptoms, including overactive bladder, so present with nocturia or urgency of frequency, voiding dysfunction, and urinary retention. Because of the indestructible confounding factor of benign prostatic obstruction in men, which has the same LUTs as diabetic cystopathy, cannot be easily excluded using appropriate measures. Some authors have assessed only female patients with diabetes after excluding other causes of lower urinary tract dysfunction. So urinary bladder anatomy. So normal bladder functions through a complex coordination of the musculoskeletal, neurological, and psychological functions. The prime effector of continence, that is a synergetic relaxation of the detrusor muscles, contraction of the bladder neck, as well as the pelvic floor muscles. This occurs during bladder filling and urine storage. So adult bladder accommodates 300 to 600 ml of urine. Central nervous system response is triggered when the volume reaches 400 ml. Urination can be prevented by cortical suppression of the peripheral nerve system or by voluntary contraction of the external urethral sphincter. Nothing but pelvic floor of muscles. So the anatomical features, we get the bladder apex, the body, the fundus, the neck, internal sphincter, external sphincter, of course, detrusor muscle, which normally plays an important role in the contractions. So we have this peritoneum, and we have the, again, apex, fundus, and the trigone. You can see the opening up of the ureter as well as the commencement of the urethra, that triangle, we call it trigone, and where the bladder neck is also situated. And we have the blood supply mainly derived from the common iliac artery as well as internal iliac artery. So the adult bladder is located in the anterior pelvis. It is separated from the pubic space by the reticulus, and bladder is anatomically divided into apex, body, fundus, and the neck. Apex is the anterior superior portion, and the body is the central portion. Fundus is the posterior inferior aspect that contains the trigone, where the ureter enters and the urethra exits, and the neck, that is a constrictor region relating to the urethra. The bladder's blood supply mainly from the branches of the internal iliac arteries, namely the superior and inferior vesical arteries. In females, additional contributions from the vaginal arteries. The neurological control is complex. Innervation of the bladder involves sympathetic, parasympathetic, and somatic, and sympathetic fibers promote bladder filling by causing relaxation of the detrusor muscle and contracting the internal sphincter. Parasympathetic fibers facilitate urination by contracting the detrusor muscle and relaxing the sphincters. So voluntary control, that is achieved by the somatic nervous system mediated by the pudendal nerve. So we have the sympathetic, hypogastric nerve, causes relaxation of the detrusor muscle. Parasympathetic, mediated through pelvic nerve, increased signals, causes contraction of the detrusor muscle. Somatic, pudendal nerve, inhibits the external sphincter, providing voluntary control. And of course, in addition, we get the sensory nerves that report to the brain. They are found in the bladder wall and signal the need to urinate when the bladder becomes full. So it has 4 layers. If you look into the mucosa, that is urothelium, lamina propria, muscularis, as well as adventitia, as well as the trigone. And this shows the microscopic anatomy. the benign nuclear cells. And this umbrella-like cells, that is the urothelium, it plays in maintaining the functional integrity of the internal lining membrane of the bladder. So, studies indicate urothelium plays an active role in iron transport, fluid homeostasis, express various aquaporins that facilitate water transport. It must withstand significant mechanical stress, very important. It exhibits remarkable plasticity during filling, expands significantly when maintaining integrity. This involves the dynamic changes in the cell shape as well as tight junction remodeling. So it plays an important role in maintaining the intact junctions. Right. Next is physiology of micturition. It is a coordinated process. Starts with the bladder filling, transferring the data to central nervous system. And we get the processing center in the pons, that is L, and as well as that is the lateral dorsal regions of the pons, as well as the M area of the pons. Processing center and different pathways resulting in the voiding response. Urothelium represents the layer of epithelial cells. It responds to various physical and chemical stimuli. Physical stimuli, mechanical stretch, chemical stimuli, that is mediated through ATP, nitric oxide, substance P, acetylcholine, adenosine, as well as cytokines. And during bladder filling, low frequency impulses activate the upper nerves, which sends signal to the pontine storage and micturition centers, stimulates the sympathetic outflow via the hypogastric nerves. The released norepinephrine induces detrusor relaxation, enhances bladder compliance, that is mediated through beta-3 adrenergic receptors. And somatic nerves also participate in the process of increasing bladder outlet resistance by releasing the acetylcholine. Increasing urine volume, that is sends upfront impulses, which in turn will shift the efferent signaling from the pontine storage. They activate the parasympathetic, inhibit the sympathetic outflow, resultant acetylcholine, stimulate the detrusor muscle through mainly M3 muscarinic receptors as well as M22 receptors, and that results in contraction and voiding. And of course, voiding dysfunction manifests in various forms, including frequency, nocturia, retention, and urinary incontinence. Two most frequent causes for incontinence are excessive pressure development or reduced bladder outlet resistance, and overactive bladder originates from the involuntary detrusor contractions during the filling phase of the micturition, and it can occur with or without incontinence. Diabetic cystopathy, pathophysiology, and pathogenesis. That is, it was recognized as a diabetic neuropathy, characterized by reduced bladder sensation, increased bladder capacity, impaired detrusor contractility, increased post-void residual urine, PVR. The earliest reference, of course, given by Calvi in 1864. The current understanding of diabetic cystopathy, it reflects progressive condition by a spectrum of clinical symptoms, urodynamic functions, ranging from overactive bladder to poorly contracted bladder, including storage and voiding systems. So diabetic cystopathy can be stratified into initial compensated stage and later decompensated or atonic stage. In the early compensated stage, storage problems with the urodynamic finding, that is diabetic cystopathy. In the later decompensated stage, it causes voiding problems, urodynamic finding of atonic bladder, that is very important. From involuntary detrusor contraction to impaired detrusor contractility or detrusor areflexia. So changes in the detrusor muscle, intracellular connections, excitability, intracellular signaling, genetic changes, they induce alterations in the bladder tissues. Next is the detrusor smooth muscles also exhibited an increased response to muscarinic agonist. So upregulation, overactivity of M3 as well as M2 muscarinic receptor density activity. There is increased detrusor smooth muscle contractility as along with increased calcium channel activity as well as enhanced calcium sensitivity. Next is neuronal impairment, somatic autonomic neuropathy, hyperglycemia exerts toxic effects, metabolic derangements leads to axonal degeneration and impairment of nerve conduction, and very important things, activation of upper nerves by the filling into stretch. It's also important, and that is also impaired. Next is decreased sensation causes bladder overdistension, and repeated overdistension causes hypocontractility. And we have the loss of neurotropic support to peripheral nerves. So urothelium releases mediators there is increased upregulation as well as activity of the muscarinic receptors, and these urothelial abnormalities impact the lower urinary tract function by altering the release of mediators as well as the sensory nerve fibers. Next is urethral dysfunction, storage and release. It requires coordination between the bladder and the external urethral sphincter. Neuropathic changes affecting the urethral, that is sphincter, making them hyperexcitable during disease progression, and prolonged hyperglycemia causes external urethral sphincter dysfunction, increasing outlet resistance and impairing urethral smooth muscle relaxation. Next is detrusor sphincter dyssynergia was found in diabetes, leading to bladder remodeling and increased post-void residual urine. So diabetic cystopathy may be related to prolonged hyperglycemia. Hyperglycemia in turn induces a number of metabolic changes, structural changes, functional changes, as well as oxidative stress. And oxidative stress causes damage to the smooth muscle cells. And bladder remodeling includes hypertrophy, dilation, increased contractility, as well as a compliance. In the late stage, decompensated bladder function, there is reduced micturition pressure and increased post-void residual urine. So management strategy. So the diagnosis can be diagnosed through urodynamic testing. So key tests include cystometry, uroflowmetry, and identify the impact contraction or increased capacity. So we gave the urodynamic study. Uroflowmetry as well as cystometry, the gold standard to assess the detrusor contractility, bladder sensation, as well as voiding pattern. Post-void residual urine, that is ultrasound, we can make out pre-void, post-void. Clinically palpable bladder, that clearly shows patient must be having non-obstructive distension. Renal function tests and urine culture, and of course electromyography, sometimes used to study the nerve conduction. So the common findings include decreased bladder sensation, increased bladder capacity, decreased detrusor contractility. So ranging from overactive bladder to a completely, that is acontractile bladder. So management goals, relief of symptoms, promoting urinary continence, preserving renal function through behavioral modalities, pharmacological treatment and surgical, and behavioral modalities, supplementation of diet with the thiamine as well as long chain fatty acids, and patient must be educated to minimize nocturnal polyuria by confining fluid intake in the morning or early afternoon, avoiding bladder irritants such as caffeinated beverages. Alcohol is also diuretic, and very important thing is maintain regular bowel habits by increasing the fiber consumption, emphasize better glucose control, BP control, and encouraging, that is cigarette smoking cessation, and pelvic floor exercises or Kegel exercise, which will strengthen the pubococcous muscles of the pelvic floor, which support the structures of the bladder and urethra. And of course, these exercises are helpful in stress, urge, and mixed incontinence. And yet another technique is insert finger into the vagina or rectum in men. Then the patient is encouraged to tighten the muscles. The abdominal and thigh muscles should stay relaxed. And patient with a hypotonic or atonic bladder treats manual compression of the lower abdomen. However, clean intermittent self-catheterization, that is a primary therapy, and the interval should be designed to maintain a residual volume of less than 400 cc, and lifestyle modification, weight reduction, changes in the diet, fluid intake, and bladder training can substantially improve the low urinary tract symptoms, and weight loss improve urinary incontinence in obese patient should be considered as an initial step. And we get the antimuscarinic agents. They inhibit the binding of acetylcholine at M2 and M3 receptors on detrusor smooth muscle cells and other structures within the bladder, thus reducing the contractions of the detrusor muscles. So patient presenting with overactive detrusor muscle activity, this M2, M3 receptor, that is acetylcholinergic or indicated, and antagonist or indicated. A meta-analysis trial found antimuscarinics are safe and efficacious. We have so many galaxy of drugs, and we have the comparison between the various group of drugs, including the sulfenazine as well as darifenazine. And trospium chloride is an anticholinergic drug. It has unique pharmacokinetic properties, and we have the physoterodine as well as trospium. And next is propionine hydrochloride. It has got antimuscarinic as well as calcium antagonistic action. Calcium also plays an important role in mediating this action. In general, anticholinergic drugs cause the side effects we know, and patient need to be monitored for retention and post-void residual urine. Patient presenting with retention, we need to put the patient on cholinergic agents like bethanacol. So a patient with impaired detrusor contractibility, not responding to lifestyle or pharmacological interventions or behavioral modifications, surgical intervention. That is bladder neck incision, selective parental nerve block, and sacral neuromodulation. And vesical neck resection, which is performed through transurethral route, leaves the external sphincter intact. So resistant reduction, that is the presence of hypotonic bladder. There is, however, risk of retrograde ejaculation in men and cystourethral in women. So in this procedure, before sending the patient for surgical treatment, this lidocaine test has to be carried out, and sacral neuromodulation is another approved method. And these are the treatment levels for diabetic bladder in different stages, starting from overactive bladder to hypotonic bladder. In conclusion, diabetic bladder dysfunction is relatively common, and diabetic neuropathy plus detrusor muscle and urothelial dysfunctions all have some role in pathophysiology, and urodynamic evaluation is a cornerstone of diagnosis and determines the actual type of bladder dysfunction and therapeutic strategies. Thank you very much for your kind listening.
Thank you, sir. Thank you for covering the very complicated and let's talk about the subject, the diabetic cystopathy.
Because of course, I'm not an urologist, so I have specifically informed Dr. Srinivasamurthy that I want to give a talk on this because this particular topic has not been covered in any of the conferences.
So from your talk, the people came to know there is
Yes, sir. Yes, sir. This is a very common problem.
Stages and how to you go to diagnose like urodynamics. I mean, you go for EMG also. And
mere simple clinical findings, sir. Palpable bladder. Put the patient on ultrasound table. Do ultrasound study. Ask the patient to pass urine. There will not be any problem in making a diagnosis.
So any comments or questions from the house?
So one of the non-obstructive cause, think of the possibility of cystopathy in the absence of benign benign prostate.
In the male adult, once you rule out the benign hypertrophic prostate,
yes, sir.
And if it is diabetic and long duration, you should keep in mind the diabetic cystoscopy.
Yes, sir.
That's
Yes, sir.
the message.
One of the causes for renal problem also.
And,
whenever we come across elderly patient presenting with elevated renal parameters, please rule out the possibility of non-obstructive cause.
Drugs, you said about the solifenacin and all.
Yes,
so
sir. Yes, sir.
Other drug, urologist usually is the other drug like beta-2 adrenergic agonist. The drug, you did not mention about that any role. I don't remember.
So we normally, that is the drugs what my urologist prescribed.
Okay.
I have enumerated solifenacin and darifenacin and then tolterodine.
Like mirabegron or something like that chemical is there. That is also used in the
Yes,
sometimes hyperactive bladder.
Yes, sir.
So thank you so much. I think if no questions are there, and so we can wind up this session here.
Thank you so much. Thanks.
Thank you so much, doctors. We request the chairperson and speakers to move to the selfie area, which is right outside the hall.